I think we saw some wonderful examples of treatment, both specific programs for drug, but also comprehensive programs. It's also nice to see collaborations between the community and governments, along with charities and the companies, all getting together in such a successful way. That was very impressive. But of course, we still see the epidemic continuing, specifically I think the MSM epidemic, which has not yet been addressed. I think also of note for those maybe in the States, genotype 3 in Europe continues to be a larger problem. And clearly there's still a lot of barriers. So maybe to lead it off, and we can have a mic from Jürgen, if you want to have maybe some initial comments, and we'll open up to the panel for discussion.
John?
Microphone 2, please.
I think this was really spectacular because I think it really sets the scene nicely. Obviously, the challenges are very different, right? We have countries who have hundreds of thousands of patients in need of treatment, and we have countries where if you could treat 2,000 or 3,000, you could eliminate the disease. So obviously, the challenges are very different. But I think one of the amazing things is also the progress from last year to this year.
Yes.
I think we have seen many countries now who have at least DA listed in one way or the other. So, but rather than echoing how much wonderful data we've heard, let me start with some of the questions. And my first question goes to Poland, which is, and where is, oh, there you are. And I have two questions. The first is, because you're one of the first countries to describe really an ongoing issue in the MSM patient population. And I want to know, is this related particularly to an increase in the use of injecting amphetamines, rather than just being blood, risky sexual practices? And maybe you want to comment on that. My second question is related to Poland and also Czech Republic, which is around the use of zaneprovir and decladisvir. I was really shocked, I have to say, that BMS does not promote the licensing of decladisvir in Slovenia, whereas you have it available. So it looks as if the company goes in some small countries, because they're small too, and it doesn't matter, but it doesn't happen in other countries. And my question would be, do you do a resistance testing in patients prior to using zaneprovir and decladisvir, as we know that NS5A mutations are very impactful in that patient population, and a lot of patients in Japan have failed with resistance, or because of baseline resistance. My question is that implemented into your guidelines?
Right, so we have Poland and the Czech Republic. So Midas, please.
Working? No? So firstly, the MSM issue, this is related to the clubbing, to the chemsex. So we do not have exact data what these people are really taking. Is it methamphetamine? Is it injectable? But it's sexual transmission and it's associated with chemsex. It's seen in large cities. It's seen in the cities where the parties are, so it's Warsaw, Kraków, Poznań, and some of our patients have come back from Berlin with Hep C. So I hope this addresses the issue of drugs, sex and rock and roll. And as for the resistance for Hep C, so the company actually has set up the program which could be sent to Germany on one hand, and on the other hand, we set up the program of sequencing locally. We have NS5A in place, we have NS3A in place, and NS5A we are now implementing to cover this need as well. So there are like two options of ascending of sequencing. So we have first sequences for the HIV, HCV co-infected, because it's the easiest material for us to get, and now the centers are starting to send the samples for NS5A sequences and NS3 sequences as well. So we are implementing this very issue of resistance. And I have a question as well on the cot. I don't know.
Wait, let's just hear from the Czech Republic on Jürgen's question.
Yes. Please, the question was about Asunapre.
Yes, you have a program and you have available to Poland to use zaneprovir and decladisvir. Now, with that combination, there is a high risk of failure, presence of NS5A mutations. So you screen for those, yes or no?
It was not idea of Hepatologic Society in the Czech Republic. It was idea another. This combination like health care insurances they recommend us it, but approval of this combination, it's not in our guidelines, because the Czech guidelines respect or follow ESO guidelines, and the Institute for Drug Control wrote something, but if you read it, you can see that they wash their hands because of this combination. So some doctors use it, some doctors not. Mostly, if some hepatologists use this combination in the Czech Republic, it's maybe in some old patient where we will not attend next treatment.
So, comments from Adrian? Thank you. Microphone 4 still. Thank you.
Well, I heard a very interesting situation in Georgia. They like in 2020 to be zero with hepatitis C, and I'm a little bit concerned due to the fact that a huge population of MSM and IV-like users. And my question is how you will deal with the reinfections in this kind of situations, because the target is fantastic.
Yeah.
And it's a little bit difficult in my opinion.
Yeah, thank you for the question. So it's ambitious target, as I mentioned, by 2020, because WHO has these targets by 2030. But I mentioned in my presentation that it's not only treatment and treatment. The major component is to implement massive screening for hepatitis C, and also there are very important steps moving towards to reduce transmission of hepatitis C among in healthcare settings, because one of the main risk factors for hepatitis C during the last data was associated with use of unsterile instruments not related to IDU. So the Ministry of Health already made major steps to improve and strengthen infection control system and infection control mechanisms in healthcare settings, in the hospitals, as well as non-medical facilities, as like beauty salons and tattoo salons. Of course, reinfection would be very important, and we have to deal with this. And one of the components which will help us, that we have a very good harm reduction network supported by the Global Fund, and they are working with drug users, people who inject drugs, and we hope that reinfection will not be so big problem which will compromise to achieve the final goal. But of course we have to think about, and it's still problem.
So we have just a question here, and then we'll...
Thank you. What I wanted to comment about the high incidence of new cases among MSM in some countries. The data from the CIALON-2 study performed among MSM has shown, at least for Romania, that because of the high stigma, more of the MSM are reaching the commercial sex workers' services, and among those who are also ID users are infected, and they promote the infection through sex. So looking in the stigma, as Poland, I know it's also a Catholic country, it's something we should see in trying to diminish, because there was not high incidence of HIV among ID users. But if those ID users are also MSM, many of them, they can be the promoters of infection, as the data showed for Romania. Thank you.
No, that's an excellent point. So we have here microphone 1, and then we'll be back.
Hello, my name is Maka Gogi. I am from Georgian Harm Reduction Network, and I want to add some comments.
Thank you.
Some comments to Georgian cases. Georgia is among first leading countries that have already elaborated Hep C elimination strategy plan. According to this plan, among high-risk groups that's targeted, that there should be screened 90% of each targeted risk group, and from them 95% should be in treatment. Among them 95% should be cured. So now in country we have broadened the screening program for total population and presented a screening program for high-risk group. We initiated mobile units to screen this high-risk population as well.
Wonderful. Important. Microphone.
Yep. So just want to, because I think the issue of stigma criminalization, which came up and what you raised and came at various places, I think is extremely important. And I want to ask our Turkish colleague, in this sense, if you look at your number of unknown transmission for HIV, which is the highest among all countries
50%,
presented, which is
yeah.
about 50%, you would presume that a large number of those, because of the low hepatitis C prevalence, have to be MSM. Because 3/4 are male, and otherwise, because women are more vulnerable for HIV, you would expect a much higher female population. So it's absolutely clear that in that hidden figure is a lot of MSM. And I think you very rightly said that you need to increase targeted screening for various diseases in at-risk populations. But how's that going to happen in an environment where there is stigmatization of certain patient groups? And I think that's one of the big challenges. And I absolutely would also echo that the aspect of reinfection, which you raised, is difficult to put against strategies which are nice to listen to, but I think it's also a reality that patients who use IV drugs may enter the prison system in Georgia, and that may be a high risk for reinfection. So I think what we have to understand is that prevention is an extremely important point. Getting diagnosis established is an extremely important, but that will demand a lot of societal and political changes and discussions, because otherwise we will not prevent reinfection of IV drug users who will re-enter through the prison system, and we will not get the MSM to volunteer and get tested because of the consequences. And that, I think, is also reflected by the fact that in the Turkish numbers, you still have a very high proportion of late presenters, which is telling me that people are only coming into medical care when they have symptoms because they're afraid to get tested before.
I think there is also a paradigm shift in that regard. The late treatment issue, I think, I may not be the right person to talk about it because I'm not treating HIV patients, but I think the late treatment issue was a little bit of an issue of the past. People are, at least the society is in that sense more open, and we have the social media. What you look from outside is totally different what people live. For example, we are a conservative country. We are 99% Muslim. And if I compare the sexual life of my youth with today's life, it's so much different. It should be because in those days Turkey was not as conservative as it is now, but in terms of sex, it's totally the other way. So I think in terms of, I think people are also much more aware, and I showed a figure about who tests for HIV, and 15% it was patient initiated. I think those numbers are going to rise because, when you engage with sex with men, you know that things can happen, people are concerned, and they would do testing. Maybe they don't admit it. The real number is not 50%, maybe higher. We don't know, but that's a possibility. But overall, I think late treatment, will be not more an issue in the coming days. That's what I think. Now, can I also ask a question? Because in terms of Georgia, the lady who's looking on her phone now, as usual, told us that they would, in terms of finding all the patients, they would look for high risk groups. Now, have you calculated what the percentage of patients with HCV is among high risk versus low-risk groups. Because, for example, I know from Delta, if you look for high-risk groups in Delta hepatitis patients in Western Europe, you find most of the patients. But that may not be applicable to HCV, which is a much broader disease. Therefore, I'm concerned that you will find all or 90% or whatever of your patients by screening just high-risk groups. Thank you.
Okay, if I understood the question correctly, yes, harm reduction programs exist in the country during the last 10 years, and they are making screenings among drug users, and the main obstacles that we are currently having is high rate of criminalization of drug consumption itself. But today, we are, in conjunction with government, we are trying to change the drug policy and regarding elimination of Hep C, and we plan to increase our screening program among drug users. I want to mention that the leading factor, one of the leading factors of HCV transmission in the country is related to drug consumption. And so far, we are covered. We have covered only 50% of drug users. This screening program. Yes, the reinfection problem will raise in some years, and as well there is currently going the reinfection assessing study in the country, and I think during next conferences we will show the results of reinfection rate. But as I mentioned previously, that screening program is not conducted not only among high-risk groups, but only in broader population, general population, and according to our target aim and target result for 2020, about 90% of population should be screened, and more than 95% should be in treatment scale, and 95% should be treated and cured for this period. But according to our contract with the Gilead Sciences, this ambition treatment plan should go till 10 years, during 10 years.
So we're running out of time, and I'm going to ask Adrian to have some final comments, and then we'll take our break.
Yeah, thank you very much, Jonathan. One of my concern is linked to the mutations that might appear during the therapy. Due to the fact that the group risk with very interesting behaviors, I think that the adherence in the compliance to therapy will not be 100%. So in such situation, when we discuss about molecules low barrier resistance, then we figured out that mutations may appear mainly in the 93 position, Y93H, which modified the fold change more than 3,000 times. So in such situation, practically you have no drugs to treat them. This might be another risk situation.
Thank you for all the speakers.